So my name is Axel Grothey. I'm a medical oncologist at West Cancer Center in Germantown, Tennessee. And this is version 2. It's kind of a subsequent meeting of a webinar where we try to get together to talk casually about advances in the management of colorectal cancer, rectal cancer, using an interdisciplinary team to really tap into some innovative, factors and innovative processes that are currently being developed for the management of our patient with metastatic and early stage colorectal cancer. And we have an esteemed panel here again. And I'd like everyone to introduce him and herself. Nina?
So my name is Nina New Sanford. I am a GI oncologist at UT Southwestern in Dallas, and I'm excited to be back for season 2, episode 2. I think what I'm very excited about chatting today in regards to CTDNA is kind of maybe separating hope and hype and promise of CTDNA versus what's feasible and real and what we should do now in clinic with the information. I know that'd be helpful to me. And then as a radiation oncologist, I'm also interested in discussing potential uses of CTDNA to better inform radiation therapy.
So you already gave it away, CTDNA. So today we'll talk about how to integrate molecular markers, new tools that we have to improve management for our patients. And we have a patient advocate. We have a patient on the panel as last time, Manju, who actually already had CTDNA testing. Manju, do you want to introduce yourself?
Mm-hmm. Hi, I'm Manju George. I'm a rectal cancer, stage 3B rectal cancer patient. I'm also the scientific director of Colontown, which is an online international colorectal cancer patient and caregiver support and education group. As a patient, yes, I've had CTDNA testing done, and it's one of the hot topics that's being discussed among patients. So I kind of want to hear what everybody has to talk about it. And yes, excited to be part of this panel. Season 2, episode 2.
Very good. Noam.
So I am Noam Vanderwalde. I'm also a radiation oncologist, specialized in GI cancers. I, as well, am very interested to hear everybody's thoughts about the use of CTDNA. Obviously, as a radiation oncologist, I don't have as much experience, I think, as some of the medical oncologists who treat, metastatic colon cancer or stage 3 colon cancer. But I'd really like to learn a little bit more about some of the possibilities of CTDNA, maybe in the neoadjuvant setting, and also in the oligometastatic setting. And maybe uses of CTDNA to help decide on local therapy for patients with metastatic disease as well.
Thank you. Josh, what's your angle?
So I'm Josh Smith. I'm happy to be back for this second episode. I'm a surgical oncologist and colorectal surgeon focusing on patients with rectal cancer as my practice, and very interested in helping patients preserve organs if we can. So I'm really excited today about seeing and talking about the evolution of rectal cancer care, and then how we might personalize rectal cancer care a bit better, and maybe CTDNA will help us do that and kind of flesh out the molecular markers and maybe make that a little bit easier to understand for our patients. And I think it's really helpful to have Manju here to help us digest some of that information and make it patient-friendly.
And you've worked with Manju on the design of a clinical trial that you're moving forward right now, which we'll come back to later.
Yeah, we're really excited about that. Yeah, thanks for mentioning that, Axel. So yeah, Manju and I have been able to design the next, what we think is the next trial integrating watch and wait, and we essentially were able to do it from scratch together, which we're pretty excited about.
Perfect. Tom, last but not least.
Yeah, last but not least, my name's Tom George. I'm a medical oncologist at the University of Florida in Gainesville, Florida, and I'm really really honored to be back, and grateful that I didn't get voted off the island. So thanks for having me.
Perfect. Tom, I'd like to actually give you a chance to discuss a platform study that your group has developed, you're leading, and tie it into what we discussed last week, when we talked about all the different news coming out of ASCO with OPERA, with Rapido, with Prodige, etc., that really, in my eyes, validated that the standard of care is now really TNT, total neoadjuvant therapy. And this is what you actually developed as a platform study a couple of years ago.
Well, thanks. It's I can't take all the credit. It definitely takes a village to pull together clinical research, and I think that the timing was right. It was the right time to bring forward some new ideas. We haven't really innovated much in the way of rectal cancer management ever since total mesorectal excision was developed, and I think it was just a matter of kind of taking that leap of faith that if we know that giving chemotherapy after surgery is hard for patients, and it's hard to ensure that everyone can get it when they need it, bringing it forward and bringing it preoperatively so that after patients recover from surgery, that's perhaps all they need and they can be done, just seemed like the right thing to bring forward. So I'm glad we had a chance to test it and validate it, and I feel like that leap of faith has now been justified with all the data that's come out of ASCO.
No doubt. So what could this trial be used? I mean, talking about new drug development, radiosensitization, different strategies for radiation. How versatile is your platform?
Yeah, so that's a great question. The study is so it's a National Cancer Institute sponsored clinical trial available at actually close to 1,000 centers across the United States. We've been really grateful for all the community uptick in participating, so that patients have a chance to get access to the trial pretty much in most communities across the country. It's designed for any patients with locally advanced or symptomatic rectal cancer. So these are patients that have either nodes that are positive, or we are suspicious that they might have cancer that's in the process of trying to spread. They have cancer that's low, and a surgery would certainly leave them perhaps with a permanent colostomy and a permanent ostomy bag, or for patients where we're really worried that their prostate or uterus or other organs in the pelvis might be compromised. So it brings all therapies to bear, starting off with chemotherapy, so induction chemotherapy with the best treatments that we know work for colorectal cancer. That's modified FOLFOX chemotherapy. We do that for about 4 months of therapy, and then move on to chemoradiation. And then after chemoradiation, the patients are reassessed and undergo their definitive surgical procedure. And so the intention is to try to shrink the cancer as much as possible and to hopefully sterilize the cancer, so surgery is just reinforcing and reassuring that all the cancer is in fact gone. And so this platform study then, with that as the backbone, allows for us to bring in and test new types of chemotherapy, determine whether or not patients may or may not benefit from additional ways of intensifying the radiation treatments, and ultimately bringing in immunotherapy as a way to perhaps allow the patient's own immune system to fight the cancer for them, in addition to what we might have to offer from a medication or radiation or surgical standpoint.
Very good. So Nina, when we, the outline that Tom just presented, based on the data that we've talked about last time, do you see more flexibility in radiation therapy here? What about your take on, I just want to recap some of the discussion that we had about short course radiation therapy. Is this a viable option, as an alternative for chemoradiation therapy?
Yeah, I mean, I think it sounds like when this trial was created, it was really to test the feasibility of doing all of chemotherapy and radiation upfront. And it seems like thus far it's been very feasible. And I have personally enrolled patients on the trial, and particularly several young patients who've done very well. So I think this trial, in combination with the trials we talked about last week, kind of putting them all together, create a great platform to talk about short course radiation and watch and wait and all those things we talked about.
Let's talk about watch and wait. And Josh, I know, and we mentioned this before, you've worked with Manju on the next trial, that Beyond Opera, which was, I think Opera was really a successful study in terms of, sphincter preservation, the extent of the preservation and the complete responses and clinical complete responses we saw were quite remarkable, which leads forward to the question of, do you really need surgery? So but I could also imagine that some patients might still have anxiety not to go to surgery. So there might be some patients who say, I want to get rid of the cancer and I don't want to have anything left behind, and the best chance, of course, to get rid of the cancer is to resect the tumor, of course, with potential consequences for permanent ostomy, depending on tumor location, etc. So Manju, is this characterized right, that there are some patients who would love to do anything to avoid an ostomy, and some patients would really like to get rid of the cancer with the highest likelihood? And you're on mute right now.
Yes, yeah, what you said is right, Axel. So that's what Josh had made a survey to really find out what did patients think. So, and I had used that in the Rectalberg group in Colintown. And there was, of course, a lot of people who did not think that they would want to not go for surgery. They wanted the tumor out as soon as they could. But again, it was like many people felt that at the time when they know that they have a cancer in the body and they're told about surgical options, that's not, especially people who have had previous exposure to an ostomy, they're able to make that, or understand what it means to have an ostomy. Whereas the other people who have never been exposed to one don't really get it. So those are factors that influence it. And the survey that Josh designed, that was really trying to find out like what amount of risk can people tolerate instead, to avoid a surgery. That was kind of, yeah.
So Josh, can you give us a little bit of an outline of the study, not going into too much detail, the statistical design, whatever, but what are you trying to test and how are you kind of controlling? Because every study needs a control arm. Who's your control arm here?
Yeah, so I think first, I think it's very difficult to randomize patients once you tell them that they have a clinical complete response, as you talked about, meaning that the tumor was there and now it's gone. And if we told them at that point, and we've spoken to many patient advocates about this, that if we said, okay, now we're going to randomize you to an APR or to watch and wait, and patients say, no way. And we've done exit interviews in patients in OPRA informally, but we'll also have some data to discuss later in that regard, but patients are not willing to be randomized at that point. So in the design of this trial, what we thought about, since randomization wasn't feasible, is that why don't we integrate patient preference? And the more that I started talking to patients, the more they wanted to be involved in the design of the next clinical trials. So we decided to take what was going to be the arm with the best organ preservation in OPRA and integrate that into a patient preference design. And the patients tell us up front whether they're interested in total mesorectal excision or watch and wait. And then we follow them using a total neoadjuvant approach, using a consolidation approach, which is chemoradiation followed by chemotherapy. And then we assess them as we did in OPRA, give them the same chance for organ preservation. And the real rub, I think, always comes at the end about the comparison group. How do we compare patients who have a clinical complete response to those who go to surgery? So the novelty here is the patient preference, but then also the control group will be comparing those patients who go on to surgery who have a clinical complete or near complete response and went on to surgery. So we'll really be able to, I think, tease out those patients who have a path CR or maybe who had a T3 and went to a T0 in one tumor and see if the outcomes are different. And we'll test 3-year disease-free survival, and of course we'll test a myriad of secondary endpoints. But I think this will be a nice head-to-head comparison. And then using, Manju was generous, but she and I developed that questionnaire and the survey together. And using that data, we know that we think the proportion of patients who choose surgery versus watch and wait helps us power the trial.
Let me ask you, I mean, and Noam, I'd like you to chime in here from an elderly patient perspective, because I know you're very interested in geriatric oncology. So patients get asked initially what their preference would be before they even start treatment. And then they go through treatment and they learn more. They learn more and they see their tumor vanish, symptoms vanish. And the question that I have is, and you know, patients might think, you know, especially elderly, but do I really need a bag? Can I change my opinion? Am I no locked in? So Noam, how would you think about this? Do you think a lot of patients will change their mind?
That's a great question, and I don't know if necessarily older adult patients are going to be any different than younger adults when it comes to changing their mind. I think everybody, as they learn more, their opinions can change. My experience actually is not as much about people changing their mind as they go through the treatment, but actually changing their mind as they meet the different specialists. So I've certainly have had patients who have met with a medical oncologist and met with a radiation oncologist and are saying that they're absolutely going to refuse surgery, and then they meet with a surgeon, find out what an ostomy really is, find out that they may be able to do their surgery laparoscopically, and then all of a sudden they say, well, I don't know, surgery doesn't sound so bad anymore. And so at least that's been my experience. Once the treatment kind of gets started, I think, I've definitely had some patients who've become less and less afraid of surgery as they've gone on. I've also had patients who have had really good responses to chemotherapy and ask the question, do I really need radiation? So I think as the treatment goes along, as patients are experiencing, improvements in their side effects, improvements in their quality of life, they then begin to question whether all the treatment is needed. I don't know.
So Manju,
what
do you think? How many patients do you think will switch their mind? And will they feel, I mean, that's my concern, locked in, okay, I said I would do this, now can I change my mind,
Yeah, I think that Josh and I had this discussion. So it all depends on what's their goal, and second, what is their understanding of how the treatment is going to be. So if you can, you don't have to scare them with anything, but if you can provide different perspectives and, expose them to this is how your life is going to be, then they are more informed to make a decision, and then they're less likely to change. And even if they change, it's not, a random, like, okay, yesterday I said this, today I'm going to change it, but it'll be more like, it'll be something that the team can make it together.
I think education about the implication of an ostomy is very important, because I see a lot of people think about, oh my God, I'm going to have a bag for the rest of my life. And I've seen patients who actually have these, let's say critical coloanal anastomosis and a lot of diarrhea, not functional sphincter, but they really try. When they eventually have an ostomy, they are so relieved, they feel so much better and quality of life goes up. I mean, so sphincter preservation by itself is not, I think, the main goal. It's more like quality of the quality of life and quality of the sphincter and function. Right. So education is a very, very critical point. And and as Noam said, this goes over time, that patients learn more about, what's going to happen. And I like what you said, Noam, that when you meet with a different person, they get a different provider. I know that I always tell them diarrhea on radiation chemotherapy comes from radiation treatment. And I know you tell them it's the chemotherapy, but, anyway. So one point that we talked about is, how can you make sure that that the cancer is gone? And Josh, I mean, I think for all of us, that's a very critical question, because we know that we don't want recurrence. We want to refine the patient population that does not have tumor recurrence. And we have imaging studies, we have clinical exams, but they only go that far. And Josh, how high is the percentage of patient that, even if you have, let's say, clinical or near clinical complete response, how many patients would progress in the end, have local recurrence?
Right. Well, we know from our retrospective data, and then also from the International Watch and Wait database, that it's about anywhere from 20 to 30% of patients have a local regrowth. The good news about those patients is that you can salvage them. They can get essentially the same operation they would have had at the beginning. The concern is always, are they more at risk for developing distant metastasis and eventually having demise from their disease because of that? But at the end of the day, maybe that's just a surrogate of aggressive disease biology from the beginning. It's hard to know. But I think what we'll learn from OPRA and other prospective studies is really what the local regrowth rate is in a prospective cohort where we know the denominator. The problem with the retrospective data is we don't have a known denominator. We're basically just looking at a numerator study going forward. So I think that will be very important to see. And I think it's important to note that in OPRA, there was no difference in the metastasis-free survival rates, and the disease-free survival rates were equivalent, and the local regrowth rates were low. And also, interestingly, the path-CR rates were similar between the two arms.
Right. So we talked about CTDNA already initially, and I'd like to use this angle to see whether we can use this tool, remarkably sensitive tool, to improve, the kind of selection of patients for non-operative management and the monitoring of patients, after in a non-operative management protocol, but even also after resection after surgery. And I know, Tom, you'll later talk about, trials that are actually actively prospectively using CTDNA data to really see how patients do in an early stage setting. Let me give you a little bit of background. I'm sharing my screen here right now. Just to set a little bit of a background about CTDNA. And I think CTDNA is going to revolutionize the way we look at various diseases, here in our case, colorectal cancer, from various perspectives, diagnosis, early diagnosis. I mean, there are even, population screening approaches right now for cancer diagnosis with CTDNA and methylation markers. What we'll focus on is minimal residual disease. How can we detect, disease before we see anything visual on imaging scans, and what's the consequence of that? Then we can use CTDNA for treatment response. That's commonly done, when we see, for instance, decrease in the amount of CTDNA that is being shed from the tumor, for instance, as a response to immunotherapy, to distinguish between, response or pseudoprogression. And then we can look at resistance markers that are developing when CTDNA is, tested sequentially over time. And CTDNA really looks at the cell-free DNA fragments that are originating in the from tumor cells. They have a very short half-life, so they normally disappear quite rapidly. And they make up the CTDNA, circulating tumor DNA, is a fraction of the cell-free DNA that's present in our bloodstream anytime due to kind of cell turnover. So it's really dependent on finding the mutations that characterize a cancer in the CTDNA. And the question of MRD detection is really to transform adjuvant therapy, because of all these patients that might go through surgery, most of them are actually cured by surgery and do not need adjuvant treatment. And but some patients will have residual disease and tumor recurrence. The question is, can we identify those patients that need to be treated and eventually gets cured with adjuvant therapy? So, and how can we better identify this beyond the markers that we have right now, CA and imaging scans? And CTDNA as marker for molecular or minimal residual disease can be tested in two different ways. A tumor agnostic test, where a panel, an NGS or PCR panel, is being developed of common mutations that we know in colorectal cancer, like RAS mutation, APC mutations, etc., or methylation markers. That's an logistically easy test, because it's a one-size-fits-all. Every patient will get the same standard test. Question is, it might be a little bit lower sensitivity than if you had a tumor-informed test, where the tumor is actually profiled, the resected tumor is profiled using an NGS or PCR panel, and then a specific individual patient-directed kit is being developed, a highly sensitive test, like the Natera Signatera test, which has, again, high sensitivity, but the logistics are more complicated, and it takes a little bit longer to develop this test in this setting. Now, why we're all excited about this, the presence of CTDNA after resection, here a study 4 years ago in colon cancer stage 2, the presence of CTDNA after resection really predicted a recurrence with high sensitivity and precision. And it was even more important than clinical low risk or clinical high risk for recurrence-free survival. The hazard ratios here are astonishing. And if you look at the positive predictive value for 3-year recurrence for a positive ctDNA test, the 8% of patients that had a positive test in stage 2 colon cancer, 100% of those patients had a 3-year recurrence, compared to patients who did not have ctDNA. And the 92% of patients were negative in ctDNA. The negative predictive value for recurrence was 91%. These are performance characteristics of tests which are remarkable. Now, one of the things we have also learned is in stage 3 colon cancer, where we normally where we normally treat patients with adjuvant therapy, because in stage 2 we don't necessarily always treat, that we can actually make a difference with our chemotherapy, because patients in this publication about a year ago, post-operative ctDNA positive versus negative, clearly a prognostic indication, when patients who are positive do worse than patients who are negative. But the curve here, in contrast to the stage 2 patients where we do not necessarily give adjuvant therapy, does not go down to kind of 0 here. So it plateaus at about 40–50%, albeit very small numbers of patients. So it seems to be that when patients are positive with ctDNA, post-operatively adjuvant therapy can actually salvage some of these scenarios and not have every patient have tumor recurrence. And it's clear that if patients are positive post-op and then turn negative on chemotherapy, they do better than if they stay positive. So we see some effect of some positive effect, potentially curative effect of the adjuvant chemotherapy. So positive ctDNA test after resection in the context of adjuvant therapy is not necessarily a point of no return. We can actually salvage some of these patients. And Tom, this is where I'd like you to talk about a little bit about the COBRA study, the design, the background, what really happened here. And this, the design, the study is activated actually, it was activated about half a year ago, suffered a little bit from COVID, I guess, and it's accrual. But can you walk us through that a little bit?
Yeah, thanks. So this is the first colorectal cancer study that's using ctDNA as a decision tool for what to do after surgery for a population of patients. So in this study, this is specifically for patients with stage 2 low risk colon cancer. So these are patients that under normal current standards of care, they would recover from surgery, have a conversation with their surgeon, not have any reason to consider chemotherapy, and would be put into a active surveillance program where CEAs and another colonoscopy in a year and CT scans would be performed for the next several times over the course of the next several years. The prognosis is very, very good for this patient population, which is why no chemotherapy is recommended for these folks. But as you demonstrated, Axel, from the previous slides and from the data that we've seen, in some patients who have ctDNA persistence after surgery, we know that that's synonymous with microscopic residual disease, and that these folks are destined to recur. Now, the question that we don't know is, can we do anything about that? That's the big question. And so it's not just a matter of being able to determine whether somebody has ctDNA positivity or negativity, but can we do anything about that, and can we change the natural history of their cancer? And do we have an opportunity to, with another shot on goal, to perhaps render them ultimately cured if they're not already cured from the surgery itself? So this study takes patients in whom we think are cured to begin with, and for whom no post-operative treatment is necessary, and randomize them. And the randomization is to do exactly what we would normally do today, standard of care, and actively monitor them for evidence of the cancer coming back in the future. The other arm, the other randomization, would be for them to get ctDNA testing done, and if their ctDNA test shows that they have no ctDNA in their blood, then great, we would continue to actively observe them and monitor them. But if they have a chance of the ctDNA being positive, they would go on to be treated just like a patient with high-risk features and would get chemotherapy. And the primary endpoint of the first component of the study is to see whether or not in those patients who are ctDNA positive, who get chemotherapy, whether we can convert them from positive ctDNA to negative ctDNA. In other words, can the chemotherapy actually change the natural course of their disease, or are we just identifying 6 months, a year earlier, patients who are eventually going to suffer from their cancer in the future, and we can't do anything about it? So that's really what this study is looking to see, is can we use ctDNA to really guide decision making for a population of patients in whom we think are cured already.
Okay, thank you. Manju, do you like this study?
Yeah, I do.
Good.
My only concern would be that it seems that a certain percentage of patients who are initially ctDNA negative could turn ctDNA positive. So that like the observation arm, I mean, because the samples are batched, you probably won't know, and there is no crossover possible, right? That would be my only concern.
Yeah, it's a great question. So the group that's in the standard of care treatment and continue on active surveillance, we will be collecting blood on those patients, but we won't actually test their blood for ctDNA status until 3 or 4 years into the future. So by then we'll be exactly where we are anyways today with continuing to check them out with CEAs and CT scans.
Yeah. So in COBRA, are you sequentially testing the ctDNA arm, and would you initiate treatment when at some point down the line, your patients turn positive?
That's a great question. We are sequentially collecting blood. We are analyzing it, but the primary decision for chemo, yes or no, is based on that first post-operative ctDNA assessment. So right off the bat, if they're positive, they get chemo. If they're negative, they don't get chemo on that ctDNA, knowing the ctDNA status arm. If they do convert to positive ctDNA, those positive ctDNAs in the future, those are also going to be batched similar to the group in the control arm. So we won't have that information in real time.
And Tom, remind us when you're checking this first ctDNA in the group that you're measuring it.
We're checking it 2 months, 2 months following the surgery.
Yeah. So within the window where we would initiate adjuvant therapy, which is kind of arbitrarily set at 12 weeks, that's because all our trials were done this way.
Right. So we're actually, we're testing it within no less than 6 weeks following surgery. So we want to make sure that the potential spike from surgery is kind of washed out.
Sure.
Right. And I think, what we learn is that the spike should be washed out anything 2 weeks beyond. 2 weeks after surgery and beyond should be fine. So we brought up an interesting question about, initiation of adjuvant therapy when a test turns positive. Because, that's an interesting, because, Tom, you're also involved in this trial design here, which I just flare up a little bit. It's called Cancer IV. That's a trial design which looks at stage 3 colon cancers where we normally give chemotherapy. And the question that we have, of course, is what if patients are negative, ctDNA negative, do they need treatment? And the design is interesting because, we assume that 65% of all patients with stage 3 or more, hopefully, stage 3 colon cancer would have negative ctDNA after resection. And then you could do a watch and wait for adjuvant therapy, test the ctDNA sequentially, and only when the ctDNA turns positive, you would then use adjuvant therapy down the line when you need it, more or less. And I think that's a very interesting concept because, it goes beyond the one-size-fits-all approach of adjuvant therapy. It's really personalized adjuvant therapy for those patients who actually have or at high risk to eventually develop visible tumor recurrence on scans. You know, did I summarize this right, Tom?
Absolutely, that was a great summary.
So Manju, what's your take on this study?
I think I like it. And it's also, you know, factoring in that some of the CTDNA negative patients may turn positive. So that's good. And then the CTDNA positive patients, are you considering that anyway, they'll start treatment, right? Because I think that some of them might turn negative without anything. Do you feel that that would be a possibility?
That's a great question. We are making the assumption that if their CTDNA is positive, it's a legit positivity. And if it was negative and turns positive, that's a legit conversion to positivity. So a positive test result at any point in time for any patient results in an intervention.
Okay, okay, yeah.
So would you test a positive result again? Would you confirm it, or are you just happy with one test?
That is under discussion, and a lot of it is highly dependent upon the assay, right? You know, the higher the sensitivity of the assay, the more confident we can be that a negative test is a legitimate negative, and the more specific the assay, the more we can be confident that a positive test is a legitimately positive assay. So, you know, we're in the process. These assays are evolving just like our clinical practices are evolving, and faster. So I think we're going to be in a good place, I think, in the very near future, with the performance of these tests really being quite good.
Yeah.
In patient, when I see patient chat rooms and whatever, there's a huge excitement and interest from patients about CTDNA, minimal residual disease, marker of response. I mean, this is something that is going to be with us. We need to learn how to interpret the data. And Nina and Noam, do you have any questions because I know this is not really what you deal with all the time, but is there anything that you would like to know, you know, because, and I can tell you, I'm not developing the CTDNA assays, but I'm using them in my clinical practice. And then I'd like to actually get your input about a clinical conundrum that I'm facing right now in terms of talking to patients. So Nina, what would you like to know?
So yeah, this conversation is really interesting, and I've already learned a lot. But one thing that I am interested in maybe talking a little bit more about is just the kinetics of CTDNA change after treatment. You mentioned the 6 weeks to 2 months after surgery, but what about after chemoradiation, such as for watch and wait? You know, is there any data on that if we're thinking of using this as a biomarker to decide on whether or not to do surgery? You know, how do different treatments affect the clearance, and is there, you know, patient variability? That's something I'm very interested in looking at. And how does radiation affect CTDNA as well?
Do you know anything about, or Josh?
So there's a study from the group that's that looked at locally advanced rectal cancers. They looked at it prospectively, and they detected CTDNA in about 77% of patients pre-treatment, but the number plummets post-radiation, down to the digits and the low teens after radiation. So we know that it's very difficult to detect post neoadjuvant therapy in the rectal cancer space. So I would, you know, my position has been there's a paucity of data in the rectal cancer space. That's why I think the data from Tom's TNT trial will be really important, and we've gathered data in OPRA. We just haven't chosen a platform because we haven't been satisfied with the sensitivity and specificity of the platforms to use yet. So I think it's important to talk about which platforms are being used, for example, in COBRA and this other stage 3 trial, because I think this will be helpful to people who are thinking about using it in the rectal cancer space.
Yeah, I think the radiation part, I think that when we measure it will be critical, since with radiation, we're not taking the tumor out. Actually, the tumor is, you know, dying and secreting, you know, cells into the bloodstream. So, you know, the timing, you know, it may not be the 6 weeks to 2 months. And I think that part will be interesting to look at more.
That's an interesting point, you know, because we have talked about actually today, this morning, you know, Noam and I in our tumor board about the kinetics of, you know, kind of tumors dying after radiation therapy. What is the appropriate time to wait until you see the maximum response? And is it different between short course radiation therapy or chemoradiation therapy perhaps CTDNA sequentially can actually give us a little bit more handle on that, Noam. What do you think?
I don't know. I think as Josh said, there's really a paucity of data in this area, and I know that there are groups out there looking to design prospective studies. The platform that you're going to use is probably going to be important. One other question, and Nina's questions are the exact questions I had as well, but one other question I had been wondering is, we talk about CTDNA being either positive or negative, right? It's either you have it or you don't. But are there levels of positivity? Are there some patients that have a lot more, CTDNA than others? And does that give us an idea of how much microscopic disease is spreading around their bodies? I'd like to know a little bit more about that as well. I know that there have been some studies, again, I used to treat some head and neck cancers, and I know that there are some studies looking at HPV DNA and looking at the levels of that and trying to decide on what treatments to use after that. And I'm wondering if there's any look at that in the colorectal world, also looking at the levels of CTDNA positivity.
Yeah, so we do know from advanced disease, for instance, that certain metastasis locations shed differently, like peritoneal disease, not a good shedder. Mucinous tumors don't shed as well as, let's say, non-mucinous tumors. So there are some tumor-based characteristics, whether or not the level is higher. I'm not quite sure about, earlier stage disease, MRD situation, whether we can already make a good call on that, Tom, is that what you hear?
Yeah, so we, in the COBRA trial, we had to specify a cut point for what we were going to call positive versus negative. And that negative determination was based on the performance of the assay, not necessarily patient characteristics, but more a function of the assay itself. Because there can be some false positives, and you get a little bit of contamination with a false positive, and suddenly, if your threshold is too high, you've now declared somebody positive and treated them unnecessarily with chemo potentially, or told them that they have a very high chance of the cancer actually being there, and we can't do anything about it. I mean, that's a lot of burden to bear with a test result.
That brings me to my conundrum that I have right now, because I have two patients who both had higher risk stage 3 colon cancer, right-sided actually both, no BRAF mutation, who had kind of due to chemotherapy intolerability aborted oxaliplatin-based therapy. They never went through not even 3 months of Kpox or whatever FOLFOX. And in one patient, I saw him actually today, the Signatera test, which we use, a tumor-informed test, which really only gives you positive or negative, and then some mutational burden, that they find in the assay. Negative, 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 and all of a sudden it was positive. Tiny amount positive. So 0.06 MTV, which is what MTM, what they use as their marker. The other, and actually I'm going to repeat the test, 4 weeks later to see is it a real positive test. Another patient, had the same, phenomenon, but it's a negative, then she turned positive, and it's confirmed positive. So actually with a rise in the MTM, which makes me believe, this is real. So both of their adjuvant therapies were complete or they aborted within the last 6 months. What do I do? So I know that the risk of recurrence is extremely high. And, and both, and, it's like, when you don't test, you don't have cases, and now I test it and I have 2 cases, And the question is, what do I do? And I can tell you what I did. So first of all, I confirmed the positivity, because I think we need to be very sure that this is not a false positive result. And I think that's very important. Secondly, these patients had negative CAT scans, but I did order an MRI liver, because that's the organ with the highest yield, and we have higher sensitivity with an MRI and with an EOS MRI, then with CT scans, because this could be ablatable lesion or follow, something that I could detect, because we really want to see, can we do something about that? And I ordered a PET scan. CA is negative, of course. Both CA is negative, CT scan is negative, and then the question is, what if I don't see anything? What do I do? Should I wait until something happens? And Manju, this is discussions I had with patients actually now twice in the last 2 weeks. So what would your take be here?
Yeah, we had the conversation going on Twitter.
Yeah, right.
So for me, if it was my personal situation, yes, I'd like, additional testing. And then my point would be that, like, even if I was not going to get any chemo, I would assume that whatever is growing in my body is so small that, when it shows up on the CT, I would have still caught it earlier, because I'm expecting it, and probably we'll have more frequent scans. The other thing that we talk between patients is this, that if you, like, the lead time they say is like anywhere from 6 months to a year before something shows up on the CT. And like, if you think of me, I had to rearrange things to get chemo. Like, I had to have somebody be at home and, manage things. So those are the kind of things that I would be thinking. Like, I had said on Twitter that I'd go to India, visit my parents, do the things that I want to do, and then be ready for chemo when it begins. That's what I would do. And especially with a test like Signatera, which is tumor informed, when compared to the tumor naive liquid biopsies, like, we have had cases in Town where patients have had other, non-tumor informed tests, and it'll show up positive and then it'll go negative, and then it'll come back positive. So those situations are even more like, it's hard to know what's going on, whether it's real or not. But I feel that the Signatera test is more reliable because you can see over time how the amount of the mutations are going up. So
yeah,
that's kind of what I
Tom, coming back to the question, should you retest? I would definitely think you need to retest a positive, because because the consequence of a false positive is too enormous,
Mm-hmm, mm-hmm. And then, if I may say this, I find that, like, many of the people, so in Town, we have the stage 2 and stage 3 patients who come, who are members and who get treatment, and they stay during the treatment, and then they are usually, not continuously present. And then we have people, when they have a recurrence, then they come back as stage 4. So what I've seen in many cases is that they realize when they have a recurrence that, after the chemo, when they had a scan, they had a shadow on their lung or liver, and they were told that it was benign. So that's another thing that I would do, that if I get my Signatera positive, I'd go back and look at my scans and have somebody look at it again to see if there is something that is there that was, like, marked as not cancer. So.
Yeah, Josh, the workup that I described, is that what you would recommend? From this, because eventually, what we all hope, if we detect things early enough so that eventually a surgeon can take care of it with metastasectomy, etc.
Sure. Yeah, I think this brings up the idea of the shared decision making that goes along with this, and how you bring the patient in, and it's a very intimate discussion, and we have these discussions all the time in patients who have watch and wait, and oftentimes we feel things when we do our physical exam before anything shows up on MRI or CT. For example, I've recently taken a patient to the OR for salvage resection, and sure enough, we found tumor, and it's something we just we felt with clinical suspicion. So I think if your clinical suspicion is there, I think what allows you to confirm that clinical suspicion now is the use of molecular testing. The CTDNA now gives you a head start on that, and I like what Manju said about allowing the patient some mental preparation time to start thinking about, what is this going to mean for me? How I'm going to need to change my life? What things am I going to need to get in order in case, Dr. Grothey wants to start chemotherapy on me? What am I going to need to think about doing? So, and I do think repeating the test, just like, if I'm worried about something, I just bring somebody back in a month and we repeat the exam. It's I think a very similar process. You don't, like I think Tom alluded to, and you did, you don't want to, completely change course based on a false positive.
Right. I think that's something where we really can talk about, recommendations or guidelines, how should we handle that? Because, right now it's a pretty, fact-free or data-free field. We might have consensus opinions, whatever, and we need to learn how to interpret the data and how to really see in how many patients does this change course, how many patients get cured by earlier detection? Is this a chance, etc.?
Axel, can I ask a quick question?
Yeah, no, yeah.
Sorry to interrupt. I know sometimes the science in the clinic, the clinic kind of comes before the science sometimes. And I was wondering, Manju, you've already had CTDNA testing, and Axel and Tom, it sounds like you guys do a lot of this already in your clinics. Do you worry that it might be hard to have patients go on randomized studies where they would not have CTDNA testing? Has this already become kind of standard of care in medical oncology clinics?
I think that in Colintown, there is a lot of discussion about CTDNA, and if I may say this, especially for rectal cancer patients, most of the trials that are now, they're for colon cancer patients. So this is something that rectal cancer patients feel really badly about. And the other thing is that even with Signatera testing, because it requires tissue upfront to select the gene panel, many of the rectal cancer patients, by the time they go through treatment, there is no tissue because the tumor has shrunk, and they can't find enough genomic DNA to standardize the test. So rectal cancer patients especially feel sidelined. I mean, I just kind of want to say it that way. But yes, in the what I can see from patients, everybody is interested in getting ctDNA testing. Yeah.
I mean, there are emerging data that the initial rectal biopsy could be used for the profiling of the cancer to then develop a tumor-informed test. So I think, that is something we don't have that much data on, but I think it is technically feasible. So hopefully at some point, rectal cancer patients won't be left out. That I think is an important point.
Yeah, I agree. I mean, I think that's where the gold dust is in those pre-treatment biopsies. And
yeah, I completely agree.
We can grow organoids from those little tiny 2 millimeter biopsies. We can certainly expand to get enough DNA to inform some ctDNA tests.
So great discussion about ctDNA. One topic we wanted to talk about is, and I think Noam, you brought this up, is neoadjuvant treatment in MSI high tumors. Because rectal cancer patients, and we're going to talk about rectal cancer, the frequency of MSI high tumors is not very high. I mean, I would guesstimate it's probably about 2%, if that's not even that. But MSI high tumors seem to have some differential response to treatment, because we know from at least the Foxtrot study, which is a colon cancer study, that they do not necessarily respond well to FOLFOX. So part of the TNT approach might change. So Noam, but do we have data on radiation therapy?
I think there have been some kind of retrospective studies looking at that. I'm not aware of kind of good prospective data on that. However, I know that some of the ongoing rectal cancer studies have been testing that and are planning on looking at that. But Tom might be able to tell us more about that. I don't know, Tom, what do you think?
Yeah, it looks like the incidence of MSI high rectal cancer, or the presence of MSI high in rectal cancers, is actually way less than 2% even. I mean, Axel, that may be a really overestimate. It looks like it's only about 0.5% so it's a unicorn. When you find a MSI high rectal cancer, then it's very, very uncommon. That being said, though, we think that these patients may actually confer a fair amount of benefit from radiation, and obviously that introduces the whole idea of whether immunotherapy in that patient population, much like in metastatic colorectal cancer, could be really valuable. Whether we can just completely do away with chemo entirely and have a chance for the patient to be rendered disease-free just with immunotherapy and maybe a boost of RT, or the other way around, RT as an accelerant for the immune system.
Yeah. Nina, you were nodding earlier. You know, do you have any experience with MSI high tumors and radiation?
Not really. No, I was just nodding that we need much better biomarkers of predictiveness of response to radiation in general. Yeah. And that's an area that we definitely need more research and information in.
I mean, it's interesting. I can see you know, we're dividing up rectal cancer, colon cancer in so many subgroups, you know, and it's what we talked about last week and what we're talking about today is really individualized care for patients. There are so many moving parts that we can talk about, you know, radiation component, chemotherapy component, sequential use, what kind of radiation therapy, can we treat patients based on biomarkers, you know, MSI, what about an ATM mutated tumor, you know, which we once in a while see, you know, that's probably a great candidate for radiation therapy, even though there's, you know, some hesitation of radiation oncologists to treat ATM mutated tumors. But it's fascinating to see, and I can only think, you know, right now we perform a lot of the comprehensive molecular profiling in advanced disease to help us choose palliative therapies. But I believe, you know, the next step is to use molecular profiling in early stage disease to do better neoadjuvant treatments, better prognostication, predictive factors, etc., for our patients, because that's where the cure actually is. So we're moving from metastatic disease to earlier stage disease, and hopefully in various different cancers.
Yeah.
And, you know, I think discussions like that, input from patients, surgery, multidisciplinary team can help us move this forward.
Yeah.
Okay.
We do have some data, Axel, that show that the MSI high rectal cancer patients do respond completely differently to, for example, you mentioned FOLFOX versus radiation. So there's a paper out last year or earlier this year that we described that, and then there's a trial ongoing looking at using immunotherapy versus in addition to radiation, but with the potential to, you know, I think the interesting thing there could we, as Tom mentioned earlier, could you even avoid radiation if you had a dramatic response to immunotherapy? I mean, I think there's a lot of very interesting questions there, but we do know that patients, some MSI patients have had exquisite responses to radiation therapy alone. I follow a number of patients who are MSI high rectal cancer patients whose only option would have been an APR, and after radiation, they've had a beautiful clinical complete response. So I'm just watching them.
It's interesting.
I think that's such a positive note to close this off. You know, this is great. You know, long-term response with just immunotherapy and or radiation therapy. I think that's great. Manju, any last words? Anything you want to add to our discussion? Because I think we need to wrap up. It's more than an hour now.
Yeah. What you said earlier about the rectal cancer biopsies being used to find out, you know, if you're thinking about liquid biopsies, I think that in that situation, maybe we need to make everybody aware of that option, because then, you know, in many cases, the biopsy is done at some place and the surgery or the other treatments are done at a different place. And that way the tumor biopsies are lost, and you know, then that's not useful to the patient. So maybe with respect to rectal cancer and CTDNA, it's important to say that upfront, that, you know, any patient that is diagnosed with rectal cancer, maybe a little bit of the sample be saved for future use for CTDNA testing.
And perhaps also get more samples. You know, you don't just need a sample to histologically diagnosed and moderately differentiated adenocarcinoma when you do your MMR stains, but we need, because, you know, if you know that you're going to do something with those tissue, with this tissue, you get more tissue.
Yes.
That was a culture shift at our center, where we, you know, had to convince our gastroenterologists that getting the tissue just to confirm the cancer was there wasn't enough. We needed, you know, if the patient has gone through the preparation, the clearance, right, they're asleep anyways, and you're taking one biopsy, please take a second or a third while you're there anyways, just to make sure that we have enough to do all the testing that's going to ultimately help us make the right decisions together with the patient.
Yeah, great point, Tom.
Very good. Okay, I really enjoyed this. This is always fun. I mean, we could probably continue talking for another hour or so, but I think we need to wrap this up, and thank you very much. So season 1, episode 2 is in the books, you know, and yeah, thanks for participating. Yeah, take care.
Thank you.
Thank you. Bye.